Steve, that was very enlightening. I now know that TR is bad and the LV is a bullet.
It is a bullet.
It's a bullet. So does it take a bullet or is it a bullet?
I still want a recording of you saying that stents are good. That's all I got out of the whole thing.
All right, so we've got some time for discussion and certainly want to open it up to the audience as well. I guess maybe a starting point is, how do we get patients seen earlier? Because that's certainly a theme that we're all talking about. The patients that ultimately get referred for transcatheter or surgery, they're often too late. And I think that's why, Vinny talked about a high recurrence rate with repair. The transcatheter approaches are limited, can do one little thing, one approach. And I think with these really dilated, severe, torrential, massive regurgitation, bad RVs, it's too late. So how do you think we can make that impact?
Well, I think it's a lot akin to operating in the asymptomatic mitral. We have to show that we're really, really good at it. And it's sort of hard to prove it. If the only patient that we get is a patient who has a dead liver and swollen legs and so on like that, you can't make a big difference to that. But somehow that's why I think percutaneous therapies of some type have to be tried at the far end of the bell curve. And, when a patient does have severe TR or massive or torrential and so on like that, I don't think anything is going to stop that patient. Now, I think that's going to take education for cardiologists, general cardiologists, maybe general practitioners to move those patients. The TR is super important.
So I think that's a really important point, because when we look at how did we go about with AS, and Mike, Mac, I'd love to get your input on this. We went about taking the sickest patients and randomizing to medical therapy, and lo and behold, there was a huge impact. Can we do that for TR? I mean, to Steve's point, it might be too late. How do we get this out there? If we're looking at those very extreme patients, I feel like we're going to fail.
Well, I think the analogies to aortic stenosis is it is the same in the fact that, as surgeons, we thought we were operating on everybody with aortic stenosis, but in point of fact, we're operating on a minority of those patients. It's the same thing with tricuspid valve, but this is forewarned as forearmed. We learned the lessons the hard way with aortic, that there are patients that truly are futile, and I think we are smart enough from the surgical experience that we know the patients to avoid. Now, the patients won't be paying as high a price on the front end as even with a on-pump beating heart surgery. So I think that patients that we clearly avoid at surgery don't necessarily have to be avoided, but we should inch onto that slowly. The other thing I would say is that there is increasing awareness of it out there. We have a multi-specialty mitral clinic, and that mitral clinic is filled up with mitral annular calcification and TR now. I mean, we're seeing very few MR patients that don't have one of those two problems. So I think it is getting out there. And a lot of it is education of sonographers to image the tricuspid well, to assess well for tricuspid regurgitation, because it is not done well in the real world out there.
I have a question. I was just interested in your programs. So as Mike alluded to, our mitral clinic is full of tricuspid patients and not full of mitral patients. To me, it seems like people are, at least in our area, are understanding that tricuspid is bad, and anytime they see any leakiness in the tricuspid, they're sending them now, but they still aren't sending the mitrals. Do you guys see that, or is it just something that we...
I don't see that. We still see a fair amount of mitrals as well. But certainly, and might be a result of the reputation of your program and the other programs up there, we're seeing more tricuspid patients because not necessarily that they're recognized differently, is that they are aware that there might be non-surgical options. And because of that, they get referred. And unfortunately, a lot of times patients screen out, and then we're left with, are they cohort A and surgical, or are they cohort B and non-surgical, or cohort C and don't do anything? And that's, I think, a lot of times what we struggle with.
Let me ask you a question that is, the tricuspid is really hard to image. You put a TE down somebody, and the mitral valve is pretty close to the esophagus, but the TE is far away. What are you thinking about the future? Maybe, Becky, you can talk about that. Are we going to move to different imagery for the tricuspid? Is ICE going to play a role in how we, image the tricuspid for earlier percutaneous sort of interventions?
Well, ICE, I don't think is going to play a role for early recognizing tricuspid regurgitation. It will definitely help in any percutaneous approach. 3D ICE is just amazing for that. But as far as imaging itself, again, I think that's just going to be education of the echo techs and the cardiologists reading the echoes to try to get good pictures. I mean, Becky, you may be able to answer more on that.
Yeah, no, I think that as we automate also our quantitation, it'll get easier for regular clinicians. So if we can automate 3D PISA, automate 3D vena contracta measurements, then we don't have to do a lot of guessing. But I wanted to say a couple of other things. One, I'm glad that all of you have recognized that this whole problem is because the surgeons failed to recognize the fact that tricuspid regurgitation is important. So that was the Nina Brunwald study really is one of the worst things that could have happened to tricuspid regurgitation. But the other thing, a couple of other points that I wanted to make. One, I think the mitral regurgitation is similar to you, Molly. We see a lot of tricuspid regurg, and I think it's because there's no class 1 guideline-directed medical therapy. A diuretic is a class 2. So, versus on the mitral side, where now all of our mitral patients are really in the heart failure clinics because they first have to undergo aggressive guideline-directed medical therapy before they come to us. The other thing I wanted to talk about as far as the annular ring and the sizing of the ring, the 26 and 28s, which are the most common size rings being put in, I mean, that was based on data that is terribly flawed. This is a three-dimensional structure. There's a three-dimensional structure. Multiple three-dimensional studies have now shown that the average annular area is 9 to 11 centimeters squared. That's your four-chamber view is the minimum dimension. Your inflow view is your maximum dimension. This is almost never a circle. And so consequently, you're telling me that a 2 to 3 millimeter gradient is okay. Well, the mean gradient across my valve and Paul's valve, hopefully, is 0.5 millimeters squared. So you've quintupled your mean gradient across on a side that requires that low gradient in order to function normally and have a normal output. So even though your mean gradient is 3 millimeters of mercury and the patients aren't presenting with terrible, tricuspid stenosis, passive congestion, you may not have done them an equivalent service as if you gave them a much larger valve.
So
Again,
Becky, let me comment on that. So you think that every tricuspid valve that we replace or put in percutaneous or surgically, you've left the patient with stenosis then? Because they all have a 2, 3, 4, 5 millimeter gradient.
I'm not saying you've left them, have you left them with a smaller valve area than they had as an adult? Yes, you've left them with a smaller valve area. I'm not going to call it stenosis because I have no idea what stenosis is for tricuspid. We've not defined that.
So I think that's a really good point for an early patient. Obviously, you don't want to affect somebody early. Remember, these studies are all on the far other end, and so they have, severe or moderate to severe TR. So we're trading perhaps a little bit of, a gradient of 2 instead of 1 for getting rid of the thing. Chris, you had a study? A question about that? A comment?
No, finish your. I had a different question.
Okay, go.
He doesn't want to talk to me anymore because he doesn't have any answers for me.
Chris Malaysley.
Chris
Your name,
Malaysley,
Chris?
Northwestern. Yeah, I had an anatomy question for the panel, and it had to do with RCA injury with tricuspid valve rings, and apropos to Mike Mack's case there as well. So there's two things that I noticed that are totally opposite. The first thing is I've never seen RCA injury after TV repair with a ring. But on the other hand, we've done TriAlign and Cardioband, Mark Ricciardi and Charles Davidson, our interventional cardiologists. And RCA injury with Cardioband and TriAlign is a real thing. So what is the discrepancy? Is it that surgeons are stupid and it did happen, and we just didn't recognize it, or is it or is it just not true? I mean, because Mike's case that he presented with that patient who never really recovered, I'm wondering if that was an RCA injury.
So there was a proposal of study in Colombia we have done is in a hybrid case, all the tricuspid repairs will have a right coronary injection to identify whether there is any spasm, and is the RV dysfunction many times we see is related to that. But obvious RCA injury I've seen only once with a deep stitch, and that's it. So that's why when classic is the case which Azim Latif showed with a cardio band, where you see RCA really, corkscrew-like, and then with GTN, etc., it opens up after some time. I just wonder, every time we do tricuspid repair, probably that's what happens. We just blame it on, pop-up effect, etc., gone now, so are we struggling?
I think it might be underdiagnosed, but I've seen it at one time as a fellow, and Mike, you should ask Rob Smith about that patient, because it was the longest patient in our cardiac ICU. Survived after 8 months in the ICU and about 15 operations, but it was because of a suture that kinked the right coronary artery. I do think it might be underdiagnosed. Scott remembers that patient too. But I think the other difference with the Cardioband is the way the anchors are placed. They're actually placed toward the direction of the RCA, whereas when we place it surgically, we go from atrium perpendicular to the annulus into the ventricle, and I think that potentially may make it safer for direct injury. I do think kinking is still possible if you really downsize a lot.
I think that's right. Yeah, we've not seen it that we've realized. We certainly may have seen it. But I think when you get to those giant tricuspid annuli that you then have to pull way down to make the leaflets coap, I don't think it's that you cross the coronary or take a bite out of it. You just periscope it and bend it on itself. And so, again, I think we won't see it that much percutaneous if we don't wait until the patient has massive or torrential TR and their RV is giant and their RCA is susceptible to that. I don't know.
Well, I think what Gaurav said about the way that you're placing the Cardioband screws, because a lot of times it's not that you're hitting the RCA. I mean, I don't think it's really ever that you're hitting the RCA. You're hitting all that tissue that's around it and it's making the RCA spasm. And I would bet one of two things. One, the way that you guys put your surgical bites in, I mean, you're visually seeing and you kind of know to stay away from that area. I don't know. No? All right.
Well, we can't see the right coronary artery, but the Cardioband procedure, actually, you're putting it in at 45 degrees to the annulus by echo, and surgically, we, in theory, may put it closer to 90 degrees. So I think go ahead, Mike, last comment.
So I would say that actually did happen in a couple of Cardioband patients early on in the European experience. And that's how the procedure evolved to putting a guide wire in and injecting the right coronary at the end of the procedure. But in point of fact, Chris, your point is a great one. We did cath that patient to see if that's what did happen, and the right coronary was normal without kinking.
Great. Thank you. I think we're going to move on to the next session.